Urogynecology Office, Can You Hold? An overview of overactive bladder. My name is Karen Noblett, and I'm professor and chair of the Department of OBGYN at the University of California, Riverside. This presentation was developed and produced with support from Pfizer Incorporated. The International Continence Society, or ICS, redefined overactive bladder, or OAB, in 2002. This definition identifies overactive bladder as a syndrome of urgency with or without urge incontinence, usually associated with frequency and nocturia, and distinguishes it from earlier terminologies such as reflex incontinence. These symptoms are suggestive of detrusor overactivity, or urodynamically demonstrable involuntary bladder contractions, but can be due to other forms of voiding or urinary dysfunction. The term overactive bladder can be used if there is no proven infection or other obvious pathology. The EpiLUTS, or Epidemiology of Lower Urinary Tract Symptoms, survey was conducted to estimate the prevalence of bother and impact of overactive bladder symptoms in the United States using current ICS definitions. EpiLUTS was a cross-sectional population representative survey. Likert scales were used to rate how often respondents experienced individual lower urinary tract symptoms during the previous 4 weeks and how much bother they experienced. Overactive bladder symptoms were categorized as occurring at least sometimes or at least often. In the total survey sample, the prevalence of overactive bladder symptoms at least sometimes was 35.6% and at least often was 24.7%. As can be seen in the figure, the prevalence of overactive bladder symptoms increased with age in both men and women. Women have a higher prevalence than men in the younger years, but in both men and women, the prevalence changes with time and increases, with the prevalence in men nearing that of women around the age of 70. A retrospective literature review was conducted to summarize the economic burden of urgency urinary incontinence in the United States on society and patients, including direct, indirect, and intangible costs. A PubMed search of the literature on the economic burden of urgency incontinence in the United States was conducted between March and September of 2012. The search encompassed publications between 1991 and 2011 for relevant articles of studies conducted in adults. Search terms included urgency urinary incontinence, urge incontinence, mixed incontinence, OAB, burden, cost, and economic. The criteria for inclusion or exclusion of the retrieved studies were established a priori, and an independent review was conducted by 3 reviewers. Studies with data on direct costs, indirect costs, and/or intangible costs were included if they provided costs specifically for adults with urgency incontinence only, or mixed incontinence, or for adults with overactive bladder with urgency incontinence. Overall, 63 publications were retrieved from PubMed search, and 2 studies were identified in the references of the retrieved articles. 58 articles were excluded, 32 did not report on urgency incontinence, 14 were focused on surgery or treatment outcomes, 11 were reviews, and 1 assessed neurogenic urgency incontinence. 7 peer-reviewed studies with U.S. cost data met the inclusion criteria and were retained for qualitative analysis and summary. Cost data were adjusted to 2012 U.S. dollars. While studies reporting the economic burden of urgency incontinence in the United States vary by analysis methods, populations, and cost endpoints reported, a consistent finding is the considerable economic burden associated with this condition for individuals and society overall. A wide range of economic burden associated with urgency incontinence was identified through this retrospective review. The overall economic burden is driven largely by direct costs. The total annual direct estimated costs in the United States ranged from $3.8 billion to $56.9 billion. The most contemporary study included in this current review estimated a total annual cost of $73 billion, which includes $56.9 billion in direct costs and $16.2 billion in indirect costs. Patient-based studies emphasize the considerable direct cost of routine care for urgency incontinence, up to $368 for mean annual costs in 2012 US dollars, and a willingness by patients to pay substantially more than routine costs of care for 50 to 100% improvement in urgency incontinence frequency. Overactive bladder may have a significant impact on the quality of life, including the physical domain, where many women limit their exercise activity. It may have a significant impact on the sexual domain, and many women start practicing avoidance behavior secondary to fear of loss of urine during intercourse or orgasm. It may also have a significant impact in the occupational realm, leading to increased absence from work and decreased productivity. Additionally, in the domestic realm, patients are being extra cautious when they go out. They are packing a diaper bag and have specialized requirements for clothing and bedding. In the social domain, there may be a significant reduction in social interaction, with many patients not attending social functions and not traveling on a plane or a bus because of lack of access to a bathroom. As you can imagine, with the impact on the physical, sexual, domestic, and social domains, the psychological domain may be affected. Many patients may start feeling guilty and depressed. They may feel a loss of self-respect and dignity. They may feel like a burden on their family, and that may lead to apathy, denial, and social isolation. There may be significant health-related problems in addition to the potential impact on quality of life for patients with overactive bladder, and these include an increased risk of falls and fractures. Overactive bladder may also lead to sleep disturbances, clinically significant depression, an increase in urinary tract infections, and skin and perineal infections. In addition, urinary incontinence is a contributing factor for admission to assisted care living facilities. Jeanette Brown and colleagues conducted a study to evaluate the relationship between overactive bladder and the risk of falls and fractures in older women. These investigators assessed the prevalence, severity, and type of incontinence in a cohort of ambulatory women enrolled in the study of osteoporotic fractures using a self-completed questionnaire. Postcards were mailed every 4 months inquiring about falls and fractures. Fractures were confirmed by radiographic reports. Logistic and proportional hazard models were used to assess the independent association of urge urinary incontinence and risk of falling or fracture. The results of this study of community-dwelling older women showed that weekly or more frequent urge incontinence was associated with an increased risk of falls and fractures by 26 and 34% respectively. Limitations of the study include the study population comprised mostly of white women living in the community. Therefore, the results may not be generalizable to the wider population. Querying the study participants every 4 months may have resulted in underreporting of falls and or fractures. The American Urologic Association, or AUA, has provided guidelines for the diagnosis of overactive bladder. Clinicians should engage in a diagnostic process to document symptoms and signs that characterize overactive bladder and exclude other disorders that could be the cause of the patient's symptoms. Most patients can be diagnosed with a simple history, symptom assessment, primarily relating to urgency incontinence or overactive bladder, physical examination to rule out any significant issues, such as advanced prolapse or a pelvic mass, and a urinalysis to rule out infection. Once these assessments have been completed, patients may be diagnosed with overactive bladder. Initiation of non-invasive treatment does not require further extensive evaluation. According to the AUA guidelines, clinicians should offer behavioral therapies such as bladder training, bladder control strategies, pelvic floor muscle training, and fluid management as first-line therapy to all patients with overactive bladder. Such behavioral approaches can be tailored to address individual patient needs and capacities. Behavioral and drug therapies are often used in combination to optimize patient symptom control and quality of life. Second-line therapies for patients with overactive bladder are comprised of pharmacological intervention with oral antimuscarinics, beta-3 agonists, and some of the antimuscarinics, which also come in a transdermal formulation. Clinicians are referred to the AUA guidelines for additional considerations for these two classes of pharmacotherapy. This slide demonstrates the different cholinergic and adrenergic receptors within the bladder. We can see here that within the detrusor muscle, the primary muscarinic receptors are M2 and M3, with M3 representing only 1/5 or 20% of the receptors. However, it is the M3 receptor that is thought to be responsible for bladder contraction, and that is why antimuscarinics are used to block bladder contraction. There are beta-3 adrenergic receptors in the detrusor muscle as well. Stimulation of the beta-3 receptors, such as with a beta-3 agonist, promotes bladder relaxation. Relaxation of the detrusor muscle during the storage phase of the bladder fill-void cycle helps increase bladder capacity. As we know, there are side effects associated with antimuscarinic medications, with the most common being dry mouth and constipation. Additionally, patients may complain of dry eyes, blurred vision, headache, and some other neurologic conditions such as somnolence or memory issues. Contraindications to the antimuscarinic medications include urinary and gastric retention, uncontrolled narrow-angle glaucoma, and known hypersensitivity. These agents should be used with caution in patients with bladder outflow obstruction, those with gastrointestinal or GI obstructive disorders, or reduced GI motility, myasthenia gravis, and controlled narrow-angle glaucoma. Additional warnings and precautions include anaphylaxis, angioedema, central nervous system or CNS effects, and QT prolongation. It is important to recognize that all noted safety issues do not apply to all antimuscarinic agents, nor does this summary include all safety information. The most recently approved oral medication for overactive bladder is a beta-3 agonist approved in June of 2012. It is a selective beta-3 agonist that stimulates the beta-3 receptor within the detrusor muscle to promote relaxation of the bladder. It is an extended-release formulation with once-a-day dosing and comes in 25 and 50 milligram doses. The most common side effects include hypertension, nasopharyngitis, urinary tract infection, and headache. Contraindications include hypersensitivity reactions. Warnings and precautions include increases in blood pressure, urinary retention in patients with bladder outlet obstruction, and in patients taking antimuscarinic agents for overactive bladder, angioedema, and patients taking drugs metabolized through the liver by CYP2D6. So when we look overall at the pharmacotherapy considerations in older patients with overactive bladder, there are some drug-drug interactions to consider, as we know that older patients often have polypharmacy. We need to be cognizant that other medications may alter the metabolism of overactive bladder medications and increase anticholinergic load, so patients may actually have an increase in their side effect profile. We also need to be aware of contraindications and comorbidities and the need for adjustment in dosing due to hepatic or renal impairment, which is true for the anticholinergics and the beta-3 agonist. For patients with overactive bladder who have failed behavioral and pharmacologic therapies or are not candidates for these therapies, third-line treatment options are available. The use of third-line therapies requires careful patient selection and appropriate patient counseling. Clinicians are encouraged to consult the AUA guidelines for information regarding these additional treatment options and recommendations. Overactive bladder is a common condition with increasing prevalence associated with advancing age. OAB has a significant impact on the quality of life, and for the older population, overactive bladder is associated with an increased risk of falls and fractures. The AUA guidelines provide framework for the treatment approach to the management of overactive bladder. First-line behavioral therapies include bladder training, bladder control strategies, pelvic floor muscle training, and fluid management with a possible addition of medication. Multiple medical therapeutic options and formulations are available for overactive bladder, including antimuscarinic and beta-3 agonist agents. Individualized treatment for overactive bladder involves consideration of comorbid conditions and related medications. For individuals who fail first and second-line therapies, additional treatment options are available in carefully selected patients with overactive bladder. Thank you.